and elaborated with the panelists today. I don't think there is a further elaborate introduction is required. We are extremely thankful to all the eminent clinicians who have joined us as panelists. At the same time, all healthcare professionals who have joined not only from West Bengal but also from the Eastern Zone. Sir, Sanofi, as you are aware, is present in allergy and many other segments. But as far as your specialty is concerned, we have many brands, and we are thankful to you for passing on the benefit to the patients. We'll continue to innovate and put our best foot forward in terms of partnering with AOI West Bengal. The topic today is going to be very interesting. The interaction, I'm sure that we'll be having some good take-home message for the audience. So, without further ado, I would request once again Dr. Subhajit Banerjee, sir, to help us by taking the proceedings ahead of this event. Thank you, sir.
Thank you, Mr. Joshi. I now request Dr. Doipan, today's speaker, to start the webinar. Dr. Doipan, please. Hello.
Yeah.
Yeah. Dr. Doipan, please. Sorry, there is some tick.
Hello, am I audible?
Yes.
Okay. Good evening and namaskar to all of you. First of all, I'd like to thank Sanofi for providing all the supports to AOI West Bengal to organize today's webinar. I also like to thank Dr. Gautam Khound, Dr. Samit Lal, Dr. Sanjeev Kumar for giving their kind consent to be present here as panelists, and Dr. Shobhendranath Bandyopadhyay, the editorial chairman of AOI and the editor of BJOHNS, to give his kind consent to moderate the session, and ex-governing body member of AOI and professor and HOD of Malda Medical College, Dr. Utpal Jana, to be present here as panelists. Our president and secretary had done a wonderful job in last 1.5 years in this COVID scenario to continue all the academic programs and sessions. So today my job is to just set the context of today's meeting, and then we will hear from all other faculties related with the panel discussion on allergic fungal sinusitis. Now my topic of presentation is managing moderate and severe allergic rhinitis. So allergic rhinitis, the most common type of chronic rhinitis, affecting 10 to 20% of the population. Globally, over 400 million people suffer from allergic rhinitis, and allergic rhinitis exerts enormous burden to the society, constituting about 55% of all allergies. And among Indians, the incidence of allergic rhinitis ranges from 20% to 30%, and over past few years, a rise in prevalence of allergic rhinitis is observed in India. But the problem is that the patients commonly think that this is a trivial disease, and they used to take medications for common cold or flu for a few days. So there is every chance of recurrence, and gradually this disease ultimately leads to frank asthma. So as ENT surgeons, we have all the responsibility to stop this allergic march from allergic rhinitis to frank asthma by providing adequate and guideline-based treatment to all the patients. Now, as we all know, there are mainly two types of allergic rhinitis: intermittent and persistent. The varieties may be mild or moderate to severe. If the allergic rhinitis symptoms persist less than 4 days in a week or less than 4 consecutive weeks, then it is called intermittent. And if it persists more than 4 days in a week or 4 consecutive weeks, then it is called persistent. Both the varieties may be mild or moderately severe. If the sleep is normal, no impairment of daily activities, sports, leisure, normal work, school, and no bothersome symptoms, then it is called mild. If all these parts are disturbed in day-to-day life, then it is called moderate to severe allergic rhinitis. Now, in recent days, according to different guidelines, gradually the understanding of this disease, the prevalence, the magnitude, and the treatment lines are gradually changing. According to Anglo M et al., all 69% patients had mild symptoms and 26% patients had moderate to severe symptoms. In another study, Amijadev M et al. Demonstrated that among patients with allergic rhinitis, 41.9% had moderate to severe rhinitis, among which 43.1% had a persistent condition. That means close to 40 to 45% of the entire patient of allergic rhinitis are having persistent and moderate to severe disease. So this is alarming, and it needs a collaborative effort from the ENT surgeons, from the pulmonologist, to actually provide adequate treatment to the patients so that we can stop this march in the early stage of the disease. Now, for the treatment of allergic rhinitis, we have different options. The gold standard is allergen avoidance. Then we are having oral antihistamines, intranasal corticosteroids, combination of intranasal corticosteroids and antihistamines, leukotriene receptor antagonists, and allergen immunotherapy. These options of treatment can be used individually or in any combination. Previously, it was actually practiced by most of the doctors to start with single therapy, and gradually, if we cannot control the disease, then we have to add other medication. But nowadays, different guidelines, they are recommending we should start with appropriate control of the symptoms of these allergic rhinitis patients. If required, then we can actually start with 2 or 3 options. Then if the symptoms are improving gradually, then we can step down all these medications from 3 to 2, from 2 to 1, and then gradual withdrawal. So we are having different types of drugs and different types of therapy to control the entire disease. Now, allergen avoidance is easier to say than to actually achieve. But avoidance of relevant allergens and irritants is the first line treatment of allergic rhinitis, and these avoidance strategies can effectively improve the symptoms of the allergic rhinitis. But for this purpose, one important thing is there. If we want to give appropriate advice regarding allergen avoidance, then it is always better to go for allergen skin prick test so that we can actually identify the exact offending allergens, and then we can actually advise to the patient that they can avoid all the avoidable allergens. And in many cases, only if the patients can identify the avoidable allergens, and by actually giving proper history and by allergen skin prick test, we can actually control this disease almost 60 to 70%. Next, first line therapy is antihistamines. Usually, the second generation oral antihistamines like fexofenadine are preferable. Usually, first generation not recommended, because first generation antihistamines negatively impact the cognition and functioning, therefore not recommended for treating allergic rhinitis, especially for the workforces. And antihistamines effectively reduces the sneezing, itching, and rhinorrhea. And antihistamines, some of the antihistamines can be considered for allergic rhinitis in pregnancy. But the one problem is there. If the patients are mainly blockers, then sometimes antihistamines cannot control the entire symptoms effectively. If the runners are there, then antihistamines can control the symptoms effectively, but only oral antihistamines cannot control the nasal congestion or blocking effectively. This is another type of antihistamine, that is nasal antihistamine called azelastine. It is available with nasal spray. The onset of action of azelastine nasal spray is 15 minutes, and there are different studies showing the efficacy of azelastine nasal spray in comparison with oral antihistamines like deslorelin or cetirizine, and in different studies it has been shown that this is quite effective. But the problem is that sometimes compliance is poor with azelastine nasal spray because of bitter taste. But nowadays some products are available and some specific sweeteners are added so that this bitter taste is not a major issue for day-to-day use of azelastine nasal spray. The next available option is intranasal corticosteroids. Undoubtedly, this is the most potent pharmacotherapy agent for the treatment of allergic rhinitis. Nowadays, ARIA, according to ARIA guideline, this can be given as a first-line therapy in all the segments of diseases. We are having different types of nasal steroid spray: fluticasone propionate, mometasone, budesonide, cyclesonide, fluticasone furoate, and all are good, but there are few important points. Number one, the duration of the action. Here the fluticasone furoate is the highest duration of action, that is 50, half-life is 15.1 hour, so it can be effectively given once in a day. The relative receptor affinity is highest for the fluticasone furoate, and another important thing is that the onset of action is 6 to 8 hours. This is very important because if we want to give only nasal steroid spray, sometimes it can take some time to control the disease. For that reason, usually we used to give these antihistamines for quick action. So in comparison to other nasal steroid spray, fluticasone furoate, the onset of action is quicker, 6 to 8 hours. So there are different comparative studies related with the most commonly prescribed nasal steroid sprays are fluticasone furoate and fluticasone propionate. There are different studies related with the fluticasone furoate and fluticasone propionate. Treatment with once daily fluticasone furoate was effective and non-inferior to twice daily fluticasone propionate in reducing nasal symptoms and faster onset of actions. For fluticasone furoate, it was observed, and according to this study, the patients preferred fluticasone furoate to fluticasone propionate based on scent or odor after taste, leaking out of the nose and down the throat, and mist gentleness. But all the nasal steroid sprays are effective, but these are some important points, that the duration of action and the dose, the bioavailability, the minimal bioavailability is always acceptable, and the receptor affinity is very important, because if there is high receptor affinity, then there is more chance of effective control of the disease, and also duration of action of the drug will be prolonged. Now, this is personalized choice for the physicians, but there are some specific advantages of combination of intranasal corticosteroid and intranasal antihistamines in one device: broad disease coverage and greater than any monotherapy, rapid symptom control, uniform distribution of the medication, greater retention in nasal cavity versus sequential sprays, less anterior or posterior runoff, and improved adherence. And as I have already mentioned, and there was some specific concern related with the taste of the azelastine, but if it can be controlled by adding appropriate sweetener, then it is wonderful, because it can start to work within 15 minutes. So if both the nasal steroid sprays and the nasal antihistamines are given, then actually symptomatic improvement of the patients will be much faster, so the compliance will be good. Leukotriene receptor antagonist is another commonly prescribed drug, but the thing is that leukotriene receptor antagonists are preferred when the lower airway is also involved along with allergic rhinitis, and it is sometimes also beneficial to combine with antihistamines in case of blockers, because antihistamines cannot control effectively nasal congestion, but leukotriene receptor antagonists are effective for nasal congestion also. And as I have already mentioned, that if we cannot control the symptoms effectively with all the pharmacotherapeutic agents, then allergen immunotherapy should be considered, and in combination with pharmacotherapy or without pharmacotherapy, but that is a very viable option to treat the allergic rhinitis, especially if the patients are having problem with unavoidable allergens like mites or dusts or some other cottons or some other unavoidable allergens. And if the patients are having persistent allergic rhinitis with moderate to severe in nature, in those cases, if we cannot control the disease with pharmacotherapy, then obviously we can offer the patients sublingual immunotherapy, and this immunotherapy option is already present in the ARIA guideline. Now, in 2020, ARIA care pathways for allergic rhinitis, there is little bit changes in the recent guideline. They are giving more emphasis on visual analog score, or if the VAS score is more than 5, then this is uncontrolled allergic rhinitis. If it is 2 to 5, then it is controlled allergic rhinitis. Means not controlled or partially controlled allergic rhinitis, and if it is less than 2, that means it is controlled allergic rhinitis. So assessment of control in untreated symptomatic patient. Untreated means those patients who didn't receive any treatment and prior to that. If the VAS is less than 5, then we can initiate treatment with any first line drug like oral antihistamines or nasal antihistamines or intranasal corticosteroids plus agilastine. Then we can reassess the VAS daily up to 48 to 72 hours. If VAS is less than 5, then if the patient is symptomatic, we then continue with the same treatment, and if no symptoms, then we can consider step down treatment, or we can stop the pharmacotherapy. If the VAS is more than 5, then we can initiate treatment, and if there is persistent allergic rhinitis, then obviously the intranasal corticosteroids and agilastine are the first choice of treatment. Then again we can reassess the VAS after 48 to 72 hours. If the VAS is more than 5, then we can actually step up and reassess VAS daily up to 7 to 14 days. And if VAS is less than 5, then we can consider step down. And if still the VAS is more than 5, then we should consider the allergen-specific immunotherapy. Now, this is the assessment of control in treated symptomatic patient. Here also, if the VAS is less than 5, then in case of intermittent rhinitis, no allergen exposure, or we can consider step down, or we can stop the medication. But if it is persistent one, then we should maintain or step up the treatment and reassess VAS daily up to 48 to 72 hours. If the VAS is less than 5, then if no symptoms, we can consider step down, and if symptomatic, then we can continue with the same treatment. On the other hand, if the visual analog score is more than 5, then we should step up the treatment, intranasal corticosteroids or agilastine, and we can reassess the VAS daily up to day 7. And if the VAS is more than 5, even after 7 days, then we can actually step up and reassess the fast daily. And if we cannot control the entire disease is by providing pharmacotherapy alone, then we should consider allergen specific immunotherapy. So with this, I'm concluding my session. Now I will hand over this session to Dr. Shomendranath Bandyopadhyay for the panel discussion. Thank you.
Thank you, Doipan. So let me share my screen now.
Sure, sure.
Good evening. Welcome to the panel discussion on allergic fungal rhinosinusitis. With thanks to Association of Otolaryngologists of India, West Bengal for this initiative and Sanofi for the support. Our panelists tonight are Dr. Gautam Khaunt, Dr. Samit Lal, Dr. Sanjeev Kumar, and Dr. Utpal Jana, all of whom have immense experience in managing patients of allergic fungal rhinosinusitis. They need no introduction. It is only a formality to introduce them to you. Dr. Gautam Khaunt is the Chief ENT Consultant of the Nightingale Hospital, Guwahati. He is the Head of the Department of ENT in Pratiksha Hospital and Consultant in Apollo Hospital. He is the Vice President, Association of Phonosurgeons of India, and the incumbent President of Indian Academy of Otolaryngology and Head Neck Surgery. Dr. Samit Lal is the Chief ENT Surgeon of Dr. Lal's ENT Hospital at Ranchi. He is a pioneer endoscopic surgeon and expertise in coblation surgeries and expertise in endoscopy, ear, nasal, and skull-based surgery. Has several publications on endoscopic surgery, and he will be there at Ranchi as the organizing secretary of AOI Con 2022 to welcome us along with Dr. Sanjeev Kumar. Dr. Sanjeev Kumar is the consultant and director of Janaki ENT Hospital and Maternity Center at Patna. He has performed over 900 endoscopic ear surgeries, and he has pioneered the endoscopic double door technique for endoscopic tympanoplasty. He is a strong proponent of the endoscopic ear surgery in central part of India. He has successfully hosted Global Endoscopy Ear Surgery Summit in February 2019 at Ashok Samrat International Convention Center at Patna, with participation of 10 countries as faculties and delegates. He is the honorary secretary of AOI Bihar and Jharkhand State Branch and founder member of the ENT Academy and Research Foundation Bihar. We have with us the very popular Professor Dr. Utpal Jana. He is presently serving as the head of the Department of ENT at Malda Medical College. He has served as professors in Calcutta National Medical College, NRS Medical College, Sagar Datta Medical College, Midnapur Medical College, and had published more than 30 different papers in national and international journals. He has served as the editor of the AOI West Bengal, the secretary. He has served as secretary of AOI West Bengal, and I should say that he is a very popular professor at present. So welcome, Dr. Khaunt, Dr. Lal, Dr. Kumar, and Dr. Jana.
Somendra, sorry to interrupt you. Are you using earphone?
Yes, yes.
Then please hold the microphone to close to
Okay,
your
okay.
so
I'll
that
do that.
your voice becomes loud.
Okay.
Okay.
I will also welcome Dr. Shubhajit Banerjee, the president of AOI West Bengal, along with Dr. Snehashish Burman, our secretary, and Dr. Doipan Mukherjee, treasurer, to be present during the session, which is supported by Sanofi. Now, an overview regarding AFRS. The fungi are present all over the environment. They are present in the nose also. However, there are several forms of sinus disease that are associated with fungi as pathogens. In some situations, rather than the fungi determining the disease process, it is usually the host immune state that determines the clinical presentation. In a setting of hypersensitivity immune response, the fungi, if allowed to remain in contact with the mucosa, they induce a strong IgE-mediated type 2 immune response and in turn leads to a polypoid inflammatory phenotype referred to as allergic fungal rhinosinusitis. AFRS accounts for about 5 to 10% of the chronic rhinosinusitis cases. Not all cases have evidence of an allergic reaction to fungi. There's a positive skin prick test or raised specific immunoglobulin E. Rather, eosinophilic chemotaxis in response to extramucosal fungi was the hallmark of inflammatory reaction in some cases of the AFRS. The term eosinophilic fungal rhinosinusitis was proposed for such cases. AFRS is a non-invasive fungal rhinosinusitis resulting from an allergic and immunologic response to the presence of extramucosal fungal hyphae in the sinuses. Though AFRS is a unique phenotype within the broader definition of chronic rhinosinusitis, the treatment differs significantly from other phenotypes of chronic rhinosinusitis with polyposis. We should have a high suspicion to detect allergic fungal rhinosinusitis. First, I will go to Dr. Count with the simulated patient, that a young immunocompetent patient who presented with unilateral or bilateral nasal polyposis with thick, sticky yellow-green mucus.
Yeah.
Now, sir, when do you consider the diagnosis to be AFRS rather than the generic chronic rhinosinusitis with nasal polyposis?
Especially when the disease is unilateral and the person has got a history of hypersensitivity or type 1 allergic problems, and the discharge that we get from the nose could be, you have already thought that it could be like a peanut butter, a cheesy side or type of material, which was actually what at one point of time called rhinitis caseosa a long time back. And you get this thick butter-like secretions coming out, and then it's yes more prevalent in the lower socioeconomic status, but it could be also in different categories. But these are the main issues clinically when you suspect more of a CRM to be AFRS instead of a CRS with poly.
So I think all the panelists will agree with Dr. Count, and we'll proceed to the next part as we already have the Bent and Kuhn criteria for diagnosis of allergic fungal rhinosinusitis, where all the 5 major criteria must be fulfilled to confirm the diagnosis. And you see that investigations play an important role in the diagnosis as also the clinical features. Now, Dr. Sanjeev Kumar, sir, if you suspect AFRS, would you like to go for initial conservative management with steroids or with antibiotics, or would you send for investigations on the day of the first consultation? Dr. Kumar, please.
Exactly. If I suspect AFRS, then the diagnosis should be confirmed before starting the management for me. And diagnosis is from some blood test, and for the antibiotics, I won't consider any role of antibiotics in AFRS.
So, sir, I'll go to all the panelists. So, if anybody wants to go for some initial conservative management initially for a suspected AFRS?
As Dr. Sanjeev Kumar has mentioned, I would definitely go for investigations, not pre-operative investigations, but I would definitely go for a CT scan at least to see the extension of the disease. And then definitely I'll put the patient on a conservative management, not as a permanent treatment. It's just a preparation for his surgery. The patient has to be exposed.
Yes. So, sir, we can conclude that medical management alone is unlikely to be effective.
Yes.
Surgery is needed. It is essential for the medical management to succeed.
Exactly.
So, we may initiate some conservative management in the meantime by the time the reports are available, but definitely we are going to go for the investigations from the very first time.
So I would like to add one thing here.
Yes.
I think pre-operative use of corticosteroids is very important, systemic, at least for a few days before you do the surgery, while you are investigating the patient, because it makes your life a lot easier while doing the surgery.
Okay.
So
we will start the conservative management with corticosteroids, topical corticosteroids at least, or systemic, sir?
Systemic. I prefer systemic steroids for 5 days before doing the surgery. It makes my life a lot easier, and anatomy also becomes a lot clearer.
So now we proceed to investigations. Dr. Samit Lal, sir, which basic investigations would you prefer to send for a suspected patient of?
The first thing I would like to do is a diagnostic nasal endoscopy. If I suspect the patient has a AFRS, the first thing I need to do is look inside the nasal cavity, do the 3-pass and see what is there inside exactly. Then, of course, the gold standard would be, and at least pre-operatively, would be a CT scan for me. A CT scan would probably give me all the clues I need to decide on my further plan of management. So these are the two basic investigations I would do right away before taking a decision.
Okay. Dr. Kumar?
Yeah.
You will also go along the same routine.
Actually, before going to CT, we should have one IgE level, because we have to categorize the disease, the non-eosinophilic with the eosinophilic, because the management is different and the pathology is different. So we need to establish whether it is eosinophilic allergic or non-eosinophilic allergic.
So how would it change your management? Excuse me, sir. How would it change your management plan?
Actually, when you have a non-eosinophilic, you have to give immunomodulator in different like clarithromycin. If you have allergic, then you have to give conservative treatment post-op immunomodulator with doxycycline. This is one. Another is when you are having allergic eosinophilic, the need of surgery will be very high. And if it is non-eosinophilic, then conservative treatment would be the most important. So categorization between eosinophilic and non-eosinophilic is I think is important, and we should don't ignore this one.
So you think we can avoid surgery in non-eosinophilic category, and the polyps will resolve?
Actually, optimal treatment should be there before committing to surgery. Okay, because surgery is not a treatment. This is a medical disease, and this is a medical immuno complex disease. So we need to establish the cause and the status, and then go for surgery, because surgery is only we are giving a passage for drug to go inside and act locally, because we can't give a corticosteroid for longer time systemic. That is the one thing.
So if you consider the aggressiveness of the disease and the probability of recurrence, the assessment of IgE or whether the disease is eosinophilic or non-eosinophilic type, we'll have to consider. But we know that the serum IgE level varies from 50 to more than 1000 IU per ml, and it varies widely. So our Indian papers, I see that they go for one thing, that total IgE estimations. The papers write about total IgE levels, and in some cases they go for skin prick test to assess the fungal specific IgE. So, sir, for IgE estimations, it varies widely, the total IgE level. And if we go for specific IgE estimation, I think that will be better. But regarding this CT scans, sir, would you advise both CT and MRI for AFRS, or you are happy with the CT scan?
Sir, I'm happy with my CT scans. The most of the time give a very, they give most of the information I need. MRI would, when there is a lot of bony destruction and it is going somewhere intracranially, intraperi or intraorbital, then maybe I would go for an MRI, but mostly CT scan suffices my need.
Yeah, I do agree with Dr. Samit Lal.
Dr. Jana?
Yes.
Dr. Jana?
Can you hear me?
Sir, yes, I can hear the CT,
Yes.
The imaging CT or MRI are very important in the treatment.
I do agree with Dr. Lal. The CT scan is the diagnostic, some important diagnostic features. And also the MRI have also some diagnostic important features. But usually CT scan is sufficient for diagnosis of allergic fungal sinusitis. And MRI is required if there is intraorbital or intracranial extensions, or in some cases for differential diagnosis, because sometimes some sarcomas may present in the CT scans like allergic fungal sinusitis. So in those cases, MRI is also very important for it to arrive at a diagnosis. So mainly in these two cases, the MRI is needed for diagnostic purpose.
Sir, as a pre-operative investigation, do you feel there is any importance of histological assessment of the mucin that can be available from diagnostic nasal endoscopy or a tissue biopsy?
No, the tissue biopsy is not required. Also, the history is not required. Biopsy is only required for differential diagnosis if we suspect a tumor or like that conditions. Sometimes some allergic fungal sinusitis may present like a tumor-like conditions. So if we have a clinical confusions after all the investigations, then we need a biopsy. Usually histology or biopsy is not required.
So basically you need to have the atopy assessed, whether the patient is allergic or not, and the CT scan will help you arrive at a diagnosis without going for.
And also the diagnostic endoscopy and findings of the allergic mucin or polyps in the nasal cavity. These are also as important diagnostic criteria, along with IgE estimations and allergic skin test.
Okay. I will again go to Dr. Sanjeev Kumar, sir. Diagnostic nasal endoscopy, as you have said, is very important and is indispensable in the management of allergic fungal rhinosinusitis. It examines the different anatomical areas. It identifies the disease. You can have microbiological sampling. You can go for documentation. It has a very valid educational tool. It is well tolerated by the patients. You evaluate the disease and also response to the treatment. But how do you prefer to perform the diagnostic nasal endoscopy? Would you like to have it as an office procedure, or you take it as in the OT setup? What will be the positioning of the patient? Which endoscopes do you use? I want to have a detailed idea for our audience about how you go for the diagnostic nasal endoscopy.
Actually, for me, it is office procedure, because we need to do all the things, because most of the time we find the polyposis and where there is no space. and we need to see the status of mucosa without treatment. So that is one thing. Flexible is not for this purpose, and I always use urodegree for this, and the spray sometimes Gylocan spray is required. So this is office procedure for me, definitely.
Yeah, totally. It's an office procedure because there's no point in taking the patient to the OT because you have to do a surgery.
Yes.
Can I come in? Can I come? For
Yes,
me,
yes, of course.
actually, I do not do it in the OPD. I do the laryngoscopies and otoendoscopies in the OPD. For a nasal endoscopy, I usually take the patient to the minor OT. I pack the nose with xylocaine and adrenaline, wait, and then do proper suctioning and then because most of the time with extensive polyposis, you hardly can see anything if you do not
Right.
decongest it. If you have a small polypi, because of that, the patient will hardly come to you. If you have just a polyp sitting in the middle near us.
There's a huge polyp most of the time.
Yeah. So those patients actually polyps will be discovered as a accidentally or incidentally. But when you need to assess, I think it's better to take the patient not into the major OT, into the minor OT where
Yeah.
the patient can lie down, and with the 0 degree only we can do it, but with proper decongestion.
No, you are
Decongestion
Yes,
suggesting
yes, sir.
proper
Yes.
decongestion before going for an endoscopy, and the patient should also feel comfortable and assured.
Yeah, I
So,
mean to say that there should be both.
yes,
The state, we know the status of the nasal mucosa and polyp without decongestant, and then you can apply congestant to see the comparative whether this is you need to know the pathological status of the nasal cavity without any alteration.
Yes, yes.
do you need to take any special measure for sterilization of the equipments for this diagnostic nasal endoscopy for AFRS?
Not always.
It's already an infected area, so we don't have to bother.
No, for your equipments, for the endoscope.
So normal standard.
Standard sterilization procedures will do.
Yes, 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 yes.
Okay.
I don't prefer nasal spray. I usually prefer to give some pack. But spray sometimes gives you some depositions in the nasal cavity and does not give some important decongestions anywhere. So Gylocaine with adrenaline pack is essential. And the most important finding, I think, in endoscopy to find the allergic mucin, because that is diagnostic for allergic fungal sinusitis. And also the other anatomical abnormality or anything other polyps like that.
And even
But I think
helps.
yes, yes, gyrometabolism and adrenaline pack is also very important. Yes.
And the look of the allergic mucin is enough to go clinch the diagnosis. You need not have to send the allergic mucin for any diagnostic procedure.
No. That look will tell you it's
that look will help you. That look will
Yes,
guide you
yes.
to the diagnosis. So there are some important differential diagnoses like chronic rhinosinusitis with nasal polyposis, eosinophilic chronic rhinosinusitis, fungal ball, inverted papilloma, granulomatous disease, malignancy, granulomatosis with polyangiitis or invasive fungal rhinosinusitis. So, don't you consider biopsy if there is any diagnostic dilemma? Dr. Count, please.
Biopsy only if I'm a little confused about the diagnosis. Otherwise, I do not do routinely a biopsy. Biopsy is not a routine procedure. Preoperative biopsy is not a routine procedure.
I totally agree with Dr. Gautam Khan. There's no point in doing a biopsy.
Yes.
Need to
Yes.
remove
Because diagnosis is depends upon the DNA and blood picture and the CT scan. So
And
tissue examination is
remove the
required.
disease. You remove the disease. You know that your CT scan, if required, you use navigation. Remove the whole disease and send it for biopsy. And then, if it is a tumor, if you are wrong somewhere, then maybe you can rethink about it. But then, removal of the disease in toto is most important.
Our panelists
Yes, yes.
have the opinion that biopsy would be unnecessary. It will not be necessary unless you are in a diagnostic dilemma. Now, regarding management, whenever you have diagnosed it as a case of allergic fungal rhinosinusitis, both the doctor and the patient are in for a committed long-term management program.
Yes.
Surgery is the first line treatment, followed by long-term medical management. Regarding how do you inform your patient about the prognosis of the disease and the course it is going to take? Dr. Samit Lal, please.
So the first thing I tell my patient, surgery will not solve your problem. Unless you will follow up with me over a period of time, do proper nasal douching as I advised you. I will need to look inside you all the time. If you get lost in follow-up, I'm 100% sure you will get the disease back. That's the first thing I tell my patient. So surgery is just one part of the treatment. Your medical management is most important. That is the follow-up after the surgery. So it is very important to tell your patients beforehand, before you do the surgery, that surgery is not the end of your treatment. Because most of the patients, they come with the mindset that, oh, mera to operation ho gaya, I'm fine after that, and I'll be back with no disease. So that is the first thing I tell my patient, that it's a long process. It's a surgery plus medical management, and post-operative follow-up is very important. And of course, I need to tell them about the recurrence, but it's not 100% efficacious.
Do you discuss the probable complications with them?
Most of the time,
Of course.
yes, sir. Most of the time. But
Yes.
hospital complications, CSF leak, these are, you need to tell your patients the risks involved with this
Yes.
kind of surgery, and the revisions also. And because these are complications which can occur at any point of time. And so the patients need to be counseled, because the times are so bad. They at their drop of a hat, they are suing doctors. They're asking for the compensation. So it is better to tell them and have it in writing, in their handwriting, that this is what the doctors told me, and still I want to go.
It should be documented.
Yes. Yes.
Now, sir, if the patient agrees, we post the patient for surgery, would you prefer minimally invasive techniques, or debride only the affected sinuses, or go for a full face? Dr. Jana.
No, there is no question of minimally invasive sinus technique in case of allergic fungal sinusitis. Always we have to open the sinus ostium, almost all the sinus ostium, largely for proper drainage and ventilations. And so a full house face is required. And also in cases of, it is also a controversial issue, if there is a one-sided disease, usually sometimes it is
I will go to that
one-sided.
question later.
Okay,
Yeah,
so it is a full house space, no question of minimal invasive technique.
Okay. So
Because ventilation
And
is so-
debride only the affected sinus. So in case of a fungal ball, that's that's not actually allergic fungal sinusitis. That should become a differentiation of the allergic fungal sinusitis. If there is only a fungal ball affecting usually the maxillary sinus or sphenoid sinus, in that case, that is removal and opening of the sinus ostium is sufficient.
So
But for allergic fungal sinusitis, yes, we would have a full house space.
Dr. Count?
Yes, I agree with Dr. Jana. If it is a infection of involving only one sinus, a maxillary antrum or a sphenoid sinus, I would definitely go for a minimal work. I would not go around opening if the other sinuses are absolutely clear on the CT scan. But most of the time, we find the disease to be extensive, so we need to open up all the sinuses.
The ventilation,
yes,
and the disease, nasal douching, reaching the area is so important. So unless you make space, your medicine will not reach. So
Yes.
Post-operative is local treatment most important. So you need to have a wide access into all the sinuses so that your surgery is successful.
So you must ensure medicine to reach all the nooks and corners of the nose and sinuses.
Dr. Bandyopadhyay, just going back to regarding the consent taking,
yes,
I picked up something from one of my seniors. I always tell these patients that we have become friends for life.
Yes.
Friends for life. So
Exactly. And one thing I always say that go and know about the allergic rhinitis, allergic disease. What is this and how you yourself prevent yourself? How can yourself avoid with this all allergic, invisible allergens around you? So go and reading, and if any extra things you need to know, then I will assist you.
So you encourage the
Yes.
patient to be a partner in the management.
Yeah.
Yes.
To Dr. Samit Lal again. Sir, would you address the uninvolved contralateral side in a unilateral case, as Dr. Jana has been pointed out?
Yes, sir. I would not. If it is one-sided disease, and then if it is only the maxillary sinus or the ethmoidal sinus or the sphenoid, it is better to leave the unaffected side with, if it has all the osteometal complexes open, and if it is aerating well, better not to touch it, because then you will be disturbing the normal mucosal ciliary system on that side. So for
Sir,
me,
one paper has appeared that in a child, it is a paper in 2017 or 18, unilateral disease, they operated it. And after 1 year, the child came back again with the disease on the other side.
on the other
Yes.
side.
And the literature shows that there is a 30% subsequent involvement of the other side. So
Yes.
it is dicey because it is not involved. The other side is not involved. I'm not going to go for surgery and open it up. And there may be a probability that the other side may also get involved in.
Yes. Yes. I have also some practical experience. I have two patients who have developed the disease in the normal side after 2 or 3 years like that.
It has happened with me.
And the operated side was okay because of the follow-up treatment, but the patients developed in the disease in the opposite side, and again I have to operate on that side.
One thing I've noticed, sir, because if there is a huge involvement on one side and the other side is not involved, mostly these patients have a deviated nasal septum. So what I do nowadays is, because I got the similar kind of thing that finished the one side, 3 years later comes on the other side. And this time it was only sinusitis and nasal blockage. So I found out that I had not corrected the septal deviation. So now I have started doing that. Even if it's the uninvolved thing, I do a septal correction in that sitting only while I'm done one side. So that is actually helps. Because then again, the aeration.
Sir, this paper appeared in European Archives of Otolaryngology. They suggested that if the contralateral side has some symptoms or radiological signs of inflammation, then you go for surgery on the other side also in the first sitting. And they have not mentioned about correcting of the nasal septum. So we get another point that if there is any anatomical abnormality obstructing the other side, the sinuses of the other side, like deviation of the nasal septum, we should correct it after clearance of the sinuses of the affected side.
It does.
So that is a good suggestion, sir.
Yes, yes. That's a good suggestion. And I know in India, there are a couple of centers which have a lot of, in our part of the country, we have quite less AFRS cases compared to maybe the north or the west or south. But I know
actually we have one input here. There is a paper regarding this contralateral normal site operation, but many of the countries there is a medical legal issue, huge medical legal issue. When even all sinuses are normal in the other side, there is no need to operate. There is another paper also. So we should always keep in mind this thing, whether you are having a preventive measurement of the development of AFRS or not. Otherwise, I think we should avoid operating in normal.
We don't have any such we don't have such medical legal issues, nor do we have insurance.
Okay. Sir, that's why it is controversial, and we have.
So it is better to do some septoplasty or make the patent the other side.
Septoplasty is okay, but operating on other side sinuses, removing the ethmoidal sinuses and opening the sinuses, that could be avoided.
Yes.
Okay, so if it is asymptomatic and radiologically there is no evidence of disease or inflammation, we should not go with explore the other side.
Yeah.
Other than this doing for septoplasty or something like that to improve the.
And there is
airway
a
other
statement by a Stemberger. Just go ahead, one cell, go ahead
Yes.
of one cell of disease. It means if the unilateral side, you have to go one head. Full house face is okay, but even CRS without allergic fungal sinusitis, the operative protocol is that one side ahead of disease is the standard protocol.
Yes.
So there is no need to go other side because other side is no disease. So overall, if I should advise to the others, and if I applied in myself, I will not operate on the normal side, even in allergic fungal sinusitis.
Okay. So we move on to the next topic, that removing the sludge or the allergic mucin is a difficult task from all the sinuses. And Dr. Jana, which areas do you find difficult to remove the sludge from, and how do you manage such difficult situations?
Usually the frontal sinus, definitely it is very difficult. Usually after opening the frontal recess, I do wash. Wash is very important with a cannula, frontal sinus cannula.
So
We take
other,
normal.
we start with the maxillary, sir.
Maxillary, usually if we do a opening and after opening the magnesium ostium, yes, and with later with the 70-degree endoscopes, we can see the anterior part of the maxillary sinus. And also this is also very important to give wash. I have experienced that during the surgery, if we repeatedly wash, the fungal material is usually comes out. And here is not to disturb the mucosa, only to remove the allergic mucin and the fungal debris. So after repeated wash on 1 or 2 times, usually the fungals comes out. As
so,
from the
when we proceed towards posteriorly to the sphenoid and frontal sinuses, how you manage? Dr.
Hello? Hello, yes.
Now we proceed to the sphenoid and frontals.
Yes. After maxillary sinus, also the frontal sinusotomy is done. And if there is, usually after frontal sinus cannula, if you wash it, then usually the fungus debris or with suction, it can be removed.
So
but it is
frontal sinus cannula serves most of the purposes.
Yes, yes, yes. But sometimes when there is a very big frontal sinus, it is sometimes very difficult to remove the fungal debris from all the corners of the sinuses.
Then what should we do? And how can we ensure that we have removed all the debris?
I think it is clinically very difficult to assess during the operations, yes, that I have removed all the debris from the frontal sinus, all the corners of frontal sinus. Yes. It is very difficult. So after repeated wash, when there is something is not come out clear, I assess that it is.
We assume yes, that it is clear.
Yes, yes, yes.
So all our panelists, does anyone want to add anything to it? And if you have any idea about image guidance system?
Yeah, actually, this surgery, the face is a surgery of landmark. And if you are operating, you have a picture of CT scan also in your mind. 2 things very important. When you are just following the landmark and having CT in mind, the chances of avoiding to go inside will be less, because you know that where we have to give a stress, where we have to see with the angulated scopes. One thing is, and second is that if landmark is preserved, you will be well oriented throughout the surgery. So I think the chances of leaving the debris will be less in these 2 situations.
In a highly pneumatized, very pneumatized frontal
Frontal
sinus,
sinus.
where you have, as Dr. Jana said, where you have doubt that in the lateral part you might be leaving behind, or where you have incomplete partitions, then I would not hesitate to actually put a eyebrow incision and make a small opening, put my scope there, and you maybe flush also through that opening, and it heals quite well.
That could be.
But
Yes, that's a good idea.
That is a good suggestion and
Frontal sinus defining.
Yes.
Yes.
Frontal sinus defining. This is a very good and practical suggestion.
But sir, image guiding system is actually very valuable.
Yes, in these cases, image guided system is definitely helpful.
Makes your life a lot easier. You know where
Yes.
you are, and a lot of disease clearance you can do. And if it is too big a sinus and not reaching the end, then modified Lothrop is, I think, a good thing to do in such cases where you know that you need to have a proper drainage. And because even after flushing out, if something is not coming out, means the drainage is not there. Then probably the chances of recurrence is there. So you have to create a huge, remove that wall and let the frontal sinuses drain. Because I've seen cases where they've done frontal trephining and it has still left, something has left behind, and then it has become an abscess and becomes very messy sometimes with frontal trephining.
So I think that will be a very good options for a revision cases.
Yeah.
That is a very good options for a revision cases.
Modified Lothrop.
Yes.
In revision cases, we can go for Lothrop.
Revision, so that is gold standard, but if we are not sure whether we've removed the clinical primary Lothrop also in the modified Lothrop.
We are discussing about the primary surgery right now.
So we can do a modified Lothrop. It's not a taboo that it cannot be done, because you know if something is going wrong, it's better to remove the disease and allow a good ventilation.
Okay. Dr. Somit Lal again. Sir, what is your take on these points, this maxillary sinus ostium widening, the amount of mucosal debridement, and how can you avoid scarring in the postoperative?
The maxillary sinus ostium in AFRS, you need to widen it adequately. You need to, I mean, for me, I follow with 70 degrees, easy to see the anterior part of the maxillary sinus. So I don't use a 70 degree only. I prefer to do it with 30 degree. And what I would do is like, I remove a part of inferior turbinate. So that until unless I get a good look of the anterior part of the maxillary sinus. So that is important. You need to have a really wide ostia in cases of fungal sinusitis.
Sir, which part of the inferior turbinate you remove?
Just inferior to the uncinate, and when you can just come anteriorly with the micro debrider, that the posterior inferior wall of the maxillary sinus is, I go a little anterior on that. So that part of the inferior turbinate I remove along with the bone, and it can be done with a micro debrider. It's not very difficult, and it can really widen that maxillary ostium nice and wide to get a good view of the maxillary sinus with your 30 degree scope, so that you're seeing each and every nook and corner of the, in fact, even with anterocornal polyp, it's very important that you see the anterior-most part. So a little bit of dissection of inferior turbinate is important. And mucosal debridement, like it is, the micro debriders are like good tools. Mostly, if it is a good healthy mucosa, you will see that it doesn't really, well, you can differentiate it between a healthy mucosa and the diseased ones. So with micro debrider, because they take 1 mm cuts, it is easier to preserve the mucosa, which is a healthy one. It's important to preserve that.
That could be the main aim of this surgery.
That has to be the main aim. So you have to preserve the normal mucosa as much as you can, because that is what will prevent further scarring and fibrosis and adhesions later on.
Now let me go to Dr. Kumar. Sir, how can you minimize scarring in the postoperative phase?
Scarring in the?
Scarring in the postoperative nose. You avoid excessive scarring or adhesion.
Actually, this is a surgery of mucosal preservation, and we are just not giving surgery, not doing surgery to removal of the disease only. We are just aiming to the mucosal preservation. When you preserve the mucosa, and most of the time the debris and the disease sinuses going to remove, ethmoidal is going to remove in toto, and we are just stimulate the drainage of the ventilation of the drug delivery of towards the sinuses, improving. So wide opening of these three sinuses without giving any bone just exposed should be the aim for me. And for the maxillary ostium widening, I always recommend that the widening should not be that much, because we have seen there is a paper that there is a lymphatic drainage of the mucosa of the maxillary sinus from the posterior, around the posterior fontanelle. So there is no need to go very wide opening and just making the fontanelle and to merge in one opening. So adequate. If I consider the papers and everything, that could be 5 mm, between 5 to 8. That could be one, and
Yes.
there should be a mucosa covering the opening. That could be the, because there to avoid scarring of maxillary ostium. That could be one thing.
In case of allergic fungal sinusitis, or sometimes we note that during surgery, the maxillary sinus ostium is usually widely opened by the disease process. Because in case of bone allergic fungal sinusitis, there is some remodeling of the bones, and also there is wide opening of the ostium. This has been noted in practically in some cases also.
True, sir.
I would like
Sir,
to add that
bleeding during
idea-
surgery.
we need to be gentle. That's the most
Yes,
important point.
that
Even
is
if
the
it's
most
an
important.
extensive disease, we need to be gentle. And now everybody uses the microdebrider. Only thing, when a novice is using the microdebrider, he should be always careful not to damage the healthy mucosa by not handling the debrider well. Because if you're pointing your blade somewhere and pressing it, you cause an inadvertent injury to the normal mucosa, and that leads to scarring again.
Yes.
So we must be gentle and discreet.
Yes, sir.
True.
So bleeding during surgery is the single most important predictor for good surgical outcome. Bleeding should be minimal during surgery. Sir, how can we ensure less operative bleeding to improve visualization of the operative field? Would Dr. Jana tell us something?
Yes, that is very important. During bleeding, it obscures the surgery, and also it initiates some complications also. So bleeding is the most important factor for doing a good surgery, control of bleedings. And it starts from the preoperative period. The preoperatively, we must use steroid at least for 7 days prior to the surgery, along with some good antibiotic, okay, and also the nasal spray. Along with, we have to control the blood pressures, and if there is some pressures, usually some antihypertensives which can be used to lower the blood pressure, the hypotensive anesthesia, the local anesthetic injections during just before the procedures, and also the merocils soaked in the adrenaline and xylocaine. Is also is an adrenaline and normal saline is also used, is very giving pack into the areas to minimize the bleeding. So all the factors that can
Sir, which
cause bleeding.
concentration of adrenaline do you use during surgery to soak the merocil packs?
Usually 10:1. I use like that.
Okay. So 1 ampoule of adrenaline in
10
10
ml.
ml of water.
Sometimes if there is a hypertensive or some patients, I use 20 also.
Okay.
10 to 20 usually. In some normal patients or child patients, no problem, 110.
Would other
Also the yes.
let others add something.
Yeah, actually, regarding the hypotensive anesthesia, recently we have witnessed, and there is a lot of paper regarding the hypotensive anesthesia. There is no need of hypotensive anesthesia. Why? Because we know we have witnessed that there is a capillary bleeding. It's not arterial bleeding and venous bleeding. There is a capillary bleeding throughout the surgery. So we need to counter the capillary bleeding. For that, we need to have a very good decongestion method, and that could tailored according to the age and according to comorbidity. Along with that could be that the heart rate should be lesser, at least
Most important,
around 60.
Below 60 heart rate.
Below
You have to
60.
ensure,
That is two most important thing. And regarding the topical vasoconstrictor, adrenaline is the best. So if you have the support of medical team and the patient profile is good, you can come down up to the 4:1. And even
Yes.
sometimes pure adrenaline could be the best to decongest. Because if you have a luxury to operate upon a younger age without any comorbidity, you can use pure adrenaline for the packing with Merosal.
So long
I
as
think
you can
this is
keep
good.
the pulse rate under control.
And
yeah.
yeah,
So long as
Yeah.
you can keep the pulse rate under control. Heart
Yes,
rate
under control, not the blood pressure. Blood pressure should be normal, that is normotensive.
So the idea behind is to reduce the microcirculation and lower the cardiac output.
Yeah.
So, so cardiac output is lowered if your heart rate goes down.
Dr. Count, do you have any experience about greater palatine block that can that reduce the amount of bleeding?
I use it only if I am doing under local anesthesia for some reason. Otherwise, I don't use it. And regarding the previous point by Dr. Kumar and Dr. Samit Lal, yes, I do agree, normotension, but heart rate should be reduced. And if there's no contraindication, the initial packing I do with concentrated adrenaline, and I do not inject anywhere in the nose. I do pack with concentrated adrenaline. It is said that adrenaline acts against adrenaline, meaning that when you initially pack with adrenaline, it is going to cause a lot of vasospasm, and that vasospasm will prevent actually absorption. So after that, when the surgery actually starts, when I put the incision, after that I do not use any concentrated. I use the diluted forms. The subsequent Merosal will be soaked in about 10% solutions.
Okay.
And, regional block, as your primary question, I have used regional block, but it's not routinely. Sometimes, if for some reason I have to do it under local anesthesia.
Sir, other than bleeding, in your practice, in your experience, what are the significant complications did you encounter for management of AFRS? Dr. Count, we'll start with Dr. Count.
Yes, apart from bleeding, immediate post-operative, you could get a little bit of injury in the lamina, and that could leave you with a edematous eyeball, a little bit of ecchymosis in the lower eyelids. And if you're on the frontal sinus, maybe a little bit of edema there also, if there is bone erosion as well, and you're doing too much of ballotment of the eyeball to see if you are near the because at times there is erosion and you are not sure that whether about your landmarks, then you have to constantly palpate the eyeball, and all those lead to a lot of edema. So sometimes you need to put ice pack post-operatively. That is mainly in extensive diseases. Then intraoperative bleed, it can occur. Commonly it occurs because of a very over-enthusiastic widening in the inferiorly, the sphenoidal ostium, and you injure the septal branch of the SPA, which should not happen. And again, over-enthusiastic widening of the maxillary ostium posteriorly, again you can injure a branch of the SPA where you can have a sparting vessel. Just you need to be patient, pack, and then you can bipolarize or even use insulated unipolar in that situation. Major, bleed, thankfully I have not had like a ICA bleed or something like that. But other you can potentially have problems with injury to the optic nerve also if you have extensive disease going in towards the mortal effects. And actually to avoid these, as Dr. Jana has suggested, because you are not dealing with a tumor, you can easily flush out most of the mucin, and that avoids, instead of trying to pull out everything, flushing out actually helps a lot in preventing injury.
Yes, sir, I want to ask all the panelists if you have faced any complication that have scared you. and you regret for not having taken adequate precautions during surgery or before that?
Nothing scary can
Nothing
happen
scary.
in stress, actually. Periorbital edema is what mostly we have encountered. Apart from that, CSF leak or injury to IC, injury to optic nerve, until really very brash and rash.
No, I went through the all literatures. What I have faced just a few months back is a very scary for me in life. It was a case of allergic fungal sinusitis with septoplasty, and this is first time I am doing a surgery. Last 2006 is almost 16 years. Ye as very beautiful young girl, and the septoplasty, my septoplasty protocol, just I remove a little bit of posterior bone, the palatine bone, and a slight bit of a strip of cartilage inferiorly, and it was almost everything was okay for 1.5 months. And in the third week of second month, the attendant of the young girl called me. There is a saddle of nose, because that attendant was the medico. Saddle of nose. I think this is कैसे हो सकता है ये, कौन, ऐसा नहीं है, आप कंफ्यूज कर रहे हो, ज्यादा पढ़ लिए हो क्या, ऐसे ही बोलो. And after 2 days, I call them that they come and visit us. I call them, and I just when I saw the patient, it was very scary and very disheartening for me. It was almost the bone, the nasal bone was almost depressed. Cartilage is okay, standing, and the nasal bone was almost depressed. And when I go inside, everything is absolutely normal. The healing is okay. All sinuses are open. Everything is okay. So this is, I think, the saddle nose after face and septoplasty. Maybe the septoplasty combined can be the reported anywhere, but for the face, saddle nose is rare complication in young, beautiful girl.
So, but why would the saddle nose occur in face?
When I go back and audit, I think that could be the because when removal of bony portion of the septum, though the nasal bone is
because of septoplasty, it's not a complication of face.
That could be.
I have injured the NLD in the early part of my career. Luckily, the patient did not realize that it was my fault. They thought it was, but it was my fault.
Sir, we are running out of time, and there are
Dr. Banerjee, just I like to luckily I have faced no complications, but in the few months back I have faced a orbital emphysema, and that develops after blowing of the nose. Patient forcefully blow the nose, and then in the post-operative suddenly he have complaints of swelling of the orbit, and then I also do some CT scan again, and then see that there is a orbital emphysema, not any orbital hemorrhage or like that. So that clears, yeah. So from that, after that was, I always advise the patients, yes, don't blow your nose in the post-operative period.
Okay.
And nothing, no other complications I have faced since that period.
So from now on, I'll go to one panelist, because we want to finish it up in next 10 minutes. And if anybody wants to add anything, they will do it. I'll go to Dr. Jana first with the first 3 points in the post-operative management. How do you pack the nose? How long will you keep the pack in situ? And what antibiotic do you use post-operatively? And how do you manage the pain in the post-operative period, immediate post-operative period?
Nasal pack is used. Usually, I give nasal pack, Merocel pack. Okay. That is for 1 day, or depending, sometimes maybe 2 days, depending on the bleedings, or sometimes some other conditions. If there is a
usually 24 hours.
Usually 24 hours. Okay. Antibiotic is for 7 days, or it may be more. depending on the conditions. Pain for this usually the first in the diclofenac injections or paracetamol infusions like that, or in the post-operative periods. Usually there is pain is not a complaint after 1 or 2 days, maybe paracetamol like that. Post-op follow-up and debridement.
Yeah, I will go to Dr. Count with that.
Yes,
question.
okay.
I will divide it because we are running short of time.
Yes.
My follow-up protocol
When,
is
sir,
basically
when do
I call
you give
after
the first post-op appointment?
7 days.
So the patient comes back to you after 7 days.
Yes.
And the first debridement?
Actually, on the first day, I do not do very frequent debridement. If I see there is extensive crusting, only then I call the patient again after 5 days. But otherwise, I call the patient later after 2 weeks again.
So, sir, first 1 week.
Then is first on 7th day we do a endoscopic cleaning of the nose, and then we start the patient on saline irrigation and nasal irrigation, proper nasal irrigation, and that actually helps to prevent too much of. I do not believe in taking away the crust too much, too frequently.
So the post-op appointments are on after the first week, then after 2 weeks, then every month or every 3 months. How do you follow up the patient?
Actually, it depends. If I find there is a complication, maybe there is some chance of some scarring, or if I find that the turbinate is lateralizing, there might be some additions forming. Only then I call them frequently. Otherwise, it is 1 week, 3 weeks, and then after 3 months.
3 months.
So it is tailored according to the need of the patient.
Yes, sir.
Yes.
So now I'm going to Dr. Sumit Lal with the question on irrigation, nasal irrigation. Sir, this corticosteroid and saline irrigation.
The most
corticosteroids can be given as spray, drops, irrigation, nebulization, and you can give it, mix it with normal saline also, or Ringal lactate. Sir, what do you prefer in the post-operative management?
Nasal irrigation with corticosteroids along with normal saline. And routinely, I ask my patients to do it for at least 3 months.
Okay, sir. How do you?
And the positioning is important. They have to bend forward and bend one way, push the fluid from one nostril and let it come out from the other nostril, and then do it the other way. With bending forward.
Sir, then in a squeeze bottle.
Yeah, in a squeeze bottle.
Yes. You mix this budesonide respules
along with normal saline.
They use it, they irrigate the nose once or twice daily?
Twice. I tell them to do it twice because see, our post-operative nasal sprays, corticosteroids, I don't think have too major a role because they will not reach to those crevices and the areas which you have created. So you have to irrigate it with corticosteroids, and you cannot, to avoid recurrence, it is very, very important that they use the nasal irrigation with steroids frequently, twice, to avoid recurrence.
Okay. And do you use normal saline or hypertonic saline or Ringal lactate? Which one do you prefer?
Mostly, I tell them to use normal saline with budesonide respules.
Sir, any advice on the temperature of the water that you use to irrigate?
It's body temperature water. I don't ask them to, room temperature water. I don't ask them to warm it or do it earlier.
Okay. Now I move on to Dr. Kumar. Sir, do you prescribe antifungals? Do you consider antifungals?
No, never.
So,
antifungal
AFRS, you do not consider antifungals. And allergen immunotherapy, sir?
Actually, allergen immunotherapy is a good idea.
Allergic immunotherapy, particularly, is at the level of the mediators like monoclonal antibodies. That could be one thing, immunoglobulin like things. But allergic immunotherapy, I don't consider.
These monoclonal antibodies are
very expensive.
Very expensive. Omalizumab, if it's available, it is very expensive. Anti-immunoglobulin E therapy. Sir, the conventional this sublingual immunotherapy.
I never consider. I never consider it very effective.
You do not consider it to be effective.
Yeah.
But a lot of people are using it, this sublingual immunotherapy, and it does seem to work.
So
Actually, the
with Dr.
mediators,
Lal,
the immunocomplex disease mediator, you have to take care of the mediators and the trigger factors. Because
what should be the mainstay in the post-operative management, sir?
for me,
For all, sir. For you? Yes.
No,
for me,
regarding allergen, Dr. Banerjee.
Corticosteroid
Yes.
irrigation, nasal saline with corticosteroid irrigation is the mainstay of therapy.
Yes, Dr. Jana?
Now, allergen immunotherapy in some now recent studies that it has definitely a role in preventing the recurrence. And we should test for the fungus which are available on the allergens, and we'll do the skin prick test also during the diagnosis. And we also convince the patients to do the allergen immunotherapy. And there are lots of articles nowadays. Though I am practically not advising now, but I think this is a good option. Yes.
Give it a thought. Okay, now saline irrigation we have described. Now, sir, regarding revision surgery, a very short session, sir. Dr. Samit Lal, how the revision surgery differs from the primary surgery?
I mean, it's a different world altogether.
Yes.
Revision surgery. So I am so used to navigation, I cannot do revision without navigation. I mean, it's impossible. But I'm in my comfort zone if I'm using navigation, because everything is distorted inside. And the patient has already had a couple of surgeries or maybe one surgery, and he's come to you for some kind of justice. Why has this happened to you?
And Dr. Count, what are the checklists for you before embarking on or thinking about a revision surgery?
If I'm doing a revision surgery, CT scan definitely is important, but the nasal endoscopic examination preoperatively is also extremely important. And the amount of, I would also look at the patient profile, how cooperative is the patient, because recurrences, you not only can blame it on the disease, it can blame it on the patients also. And maybe the previous surgeon if he has not done a complete job. So we have to take that into account. If you do not have a very good patient, a cooperative patient who does not understand his disease, as Dr. Sanjeev Kumar said, the patient needs to be educated. Then you will again, as there are many instances, all of us may have had, I had patients where I was the 9th surgeon. And all of us had multiple recurrences previously. We did not realize because our understanding of AFRS came a little late. So I think the patient's understanding of his disease condition is extremely important, rather than thinking about maybe ciliary dyskinesia or cystic fibrosis or other things. Yes, we should always ask about aspirin hypersensitivity. And in the preoperative assessment, we look at all the points that you are definitely showing here. And as I said,
so the patient profile, the patient's cooperation, the phenotype of the disease, and the availability of the patient for long-term follow-up are the important points.
Yes,
definitely.
Yes.
Now I come to the last part, the impact of COVID-19 on the AFRS. I've scanned the literature to have an idea about the impact of COVID on allergic fungal sinusitis. The main problem is the orbital complications, and people could not access the medical facilities during that period, and most of the orbital complications were due to late presentation to a medical facility. So my last question to you all is that, did you notice any change in presence of allergic fungal rhinosinusitis during the COVID pandemic, or its severity, recurrence, or invasiveness?
The mucor was...
No, that is a different issue. I have not found any incidence or higher incidence of allergic fungal sinusitis.
Only the delayed presentations might have
yes. Delayed presentations, nothing else.
Yeah, it was mucor, and much more deadly than any other. It was not allergic fungal. It was coming due to some other factors into the
Yes. The mucors also presented with polyps.
Yes.
No.
No,
Yes.
Not polyp.
not polyps, but they presented with full fungal balls all over with
Yes.
massive tissue necrosis and
And
bone
tissue
necrosis.
Yes.
So during the COVID pandemic, other than this late presentation, we did not have any significant change in the course of the disease.
Yes, definitely.
I thank our panelists for being with us for such a long time to share their experience with us. Association of Otolaryngologists of India, West Bengal is also grateful to the viewers and our members for making this interaction fruitful. Now, I think we should go for the questions, the queries.
Yes.
Neasis, are these in the chat box?
Yeah, this is in our chat box also, and also our WhatsApp group. You can see the comments and questions in the chat box,
Okay, it is.
or you can see it from our
not
WhatsApp.
working for me.
Okay,
Fast, Shumenda, stop share korun.
Oh, okay. Okay.
In the meanwhile, I'll take this opportunity to invite you all to Ranchi, all our
Yes.
panelists and all our viewers who are viewing this. We are really working hard to ensure that we have a good participation and we give you the best possible place to have a conference. We are creating a Swiss city, which is unheard of, and I can assure you it will be a place where you will think that you've come to Switzerland, and that Swiss tent city is absolutely bang next to the conference site, and so our conference site is beautiful. That's where the national games were held. So I also take this opportunity to invite everyone, and please come, and I will ensure that you people have a great time. Right, Dr. Sanjeev? Me and Dr. Sanjeev are really working hard.
You are absolutely right, Samit.
No, this is not only your responsibility, this is our responsibility, and we should ensure that maximum number of delegates should be there.
Yes.
And we must actually encourage all our colleagues in the regional level so that each and everybody should come, and most likely each and everybody eager to attend one physical conference.
Yes.
But
the COVID numbers are only 10 to 11 in Jharkhand. Every day count. So it is safe. And we've got permission from the Ministry of Jharkhand, Chief Minister also. So we are going ahead with the conference, and we've started the abstract submission, junior, senior consultant paper award submissions. So please log on to the website. You will find all the information, and please ask your PG students to present a lot. We are making 8 huge halls, so space is not a problem. Stay will not be a problem.
And we will be there.
Okay.
We will definitely be there. There are some suggestions from Dr. Soumitra Kumar that number 1 is serum IgE levels have no role. Serum specific IgE for fungus is more specific. Along with diagnostic nasal endoscopy, the mucin specimen should be sent for fungal staining and culture. Eosinophilic and non-eosinophilic AFRS is diagnosed from histopathological report of the polyp tissue removed during surgery. So he will be sending the specimen for histopathology. The question is there any role of allergic skin prick test in AFRS? I will go to Dr. Count with this question. Is there any role of allergic skin prick?
Yes, I think this has been discussed by Dr. Kumar. He spoke about it. Yes, allergic skin prick test has been advocated nowadays for in AFRS because it could be a non-eosinophilic variety where it may not be steroid responsive, number 1, and number 2, since it is a question of an immunogenic response, if we have some form of allergy which is positive for, say, dust mite or anything or some, then we can start the immunotherapy as well, which is the present trend as far as I understand.
Yes, definitely.
Another question is, what do you prefer to do to the middle turbinate after FACE, functional endoscopic sinus surgery? Dr. Jana.
Yes, if there is, it becomes, কি বলবো বাংলায়, it is unstable in the cases of the after surgery. So that should be fixed to the septum definitely by some vulgarizations, vulgarizations. And if it is better sometimes to stitch if it is not sufficient for after progressions. But it is very difficult to give stitch there, but we can give it.
Can I add something?
Yes,
Yes,
course.
definitely.
Yes, this is very important to actually medialize the middle turbinate. Another thing is from the starting point of functional endoscopic sinus surgery, it is always better to avoid corresponding raw area in the medial side of the middle turbinate and the lateral wall, because that will cause more problem. And another thing, the stability of the axilla is very important.
Yes.
If we are trying to actually push the middle turbinate laterally to approach the sphenoid sinus, and if the vertical part of the middle turbinate is very stiff, then there is every possibility of the instability at the region of the axilla, and that ultimately leads to lateralization of the middle turbinate.
Yes.
So vulgarization is one point, but on the other hand, from the very beginning, in each and every step should be taken properly so that we can avoid the lateralization of the middle turbinate.
Yes. At times we may need to trim the middle turbinate a little bit if it is a very floppy type of middle turbinate.
Yes, yes. That is also important.
Yes, sir. And I also prefer to keep the half a piece of 8 mm merosil in the middle meatus, which I actually take out on the first checkup. I keep it for 7 days.
Yeah, it's a good idea. So preserving and stabilizing middle turbinate is most important.
You keep it there and prevent.
I let the patient go. He doesn't even know that there's something there. So I call them on the 7th day and take it out on that day.
Okay, we have discussed already the role of post-phase steroid nasal douching. We have discussed it. Now, another question from Dr. Devobroto Das. If the skin prick test shows 4+ response in multiple allergens, will immunotherapy be still effective? Dr. Lal?
Immunotherapy is for 4+ positivity. If that is when it should be given.
Dr. Bandhavadai, I think they are actually tacitly mentioning the
more than 4 allergens.
Cross-reactivity.
Yeah. Okay.
Dr. Samit, most likely Devabroto is asking regarding the cross-reactivity factor.
Okay.
But see, the sublingual immunotherapy can be given only for the 3 set of allergens, because you have to give the immunotherapy twice in a week. So you cannot give more than 3 set of allergens. But if you are having 5 allergens, 3 mites, you can actually give sublingual immunotherapy to 5 allergens, because 3 mites will come in a single container.
True.
So we'll give it a try. Even if we cannot utilize all the allergens, we can start with a few. Dr. Mukherjee? What is your suggestion? We should start. We should still go ahead.
Especially mites and fungus.
Allergen immunotherapy.
Mites and fungus are the most important.
But the thing is that I should suggest that we should consider sublingual immunotherapy as one of the important tool to battle the entire disease spectrum. But simultaneously, the counseling of the patient is very important, because most of the patients, they are thinking they are taking some medication through it. But if they are having around 7-8 allergens, among them 5 or 6 are avoidable allergens, then we should not actually advise sublingual immunotherapy for those avoidable allergens. Right. But if the patients are taking sublingual immunotherapy and they are not actually avoid those avoidable allergens, then ultimately we will not actually have some benefit with this sublingual immunotherapy. So at the time of advice of sublingual immunotherapy, proper counseling of the patient is very important.
Yes.
And Dr. Lal has been suggesting that we should target the most important allergens first.
Yes, sir. Because that is if you do an allergy test, you'll find if 90% of patients are allergic to mites or house dust. And then the second category is fungus. So, and these are allergens which you cannot easily avoid. You can avoid all the other allergens, but this is one area where you cannot avoid. So it is a good idea to start them with specific 2 or 3 therapy and avoidance of other allergens. At least they'll give them some respite from the disease.
And I have seen that actually sublingual immunotherapy can do wonder if only mites or house dust are responsible.
Yes.
But if there are lots of allergens, then the benefits are somehow restricted because people don't actually try to avoid all those avoidable allergens.
Because they think they are on medication.
Yes.
That is the problem.
Okay, Dr. Prakash Munka is of the opinion that we should operate on both the sides, even if the disease is unilateral, because the allergy is sooner or later going to affect the other side. Another comment from someone, the name is IMA Chembur branch.
This is from Dr. Bikram Khanna.
Oh, Dr. Bikram Khanna. Hello, Dr. Khanna.
IMA Chembur is from Dr. Bikram Khanna.
Okay. All patients of AFRS must undergo a skin prick test to identify fungal antigen and give immunotherapy later. So he is also thinking about immunotherapy in the later stage. The other uninvolved side must be subject to douching in the post-operative period, according to Dr. Khanna. The skin prick test results must always be correlated. It is the opinion. Okay. The skin prick test results must always be correlated with the serum-specific IgE for fungal antigens before choosing the fungal antigen to be used for immunotherapy. Dr. Saurabh Sarkar says, what about using beta blocker to decrease the heart rate? Yes, it was on the slide. It was on the slide, and
you discussed it also.
It's been discussed already. But some RCT opine that hypotensive anesthesia does have a role in controlling the bleeding of surgical field.
To a certain
Dr. Saurabh Sarkar from AIMS
Bhubaneswar. Yes.
So his suggestion is that hypotensive anesthesia has a role. Yes, it has been practiced. And what about your opinion, Dr. Count?
We have moved away from that, sir. We used to insist on hypotensive anesthesia at one point of time, but practically we have also seen that just having normotensive anesthesia along with because hypotensive, another big point is that you get a good feel, and even though your heart rate might be low, when the patient comes back to normotension, then again you might have some oozing from here and there, which you did not have during the surgery. So as a whole, you get a good feel if you have prepared the nose well, prepared the patient well, positioning is good, and then I think you can have a pretty good bloodless feel.
So, can I add something?
Yes, definitely.
Yeah, I completely agree with Dr. Khan, but the only thing is that especially for the functional endoscopic sinus surgery, the perioperative bleeding or postoperative bleeding is important. But another important thing is at the time of surgery, clear field is very important for the quality of the surgery. So sometimes hypotensive anesthesia brings this absolutely clear field, and nowadays, apart from beta blocker, we are having all sorts of other medication, just like dexmedetomidine and all these things. They are actually tackling the blood pressure quite well, and some of my colleagues, they are actually now trying to do this thing under local anesthesia, that's mean TIVA with this dexmedetomidine. Hypotensive anesthesia, at least in some cases, beneficial for clear field for the surgeon.
Yes, that is of paramount importance, that we must keep a clear field. We have a proper view of the surgical field. So bleeding should be minimized, and we should not keep our windows closed regarding this beta blocker, this sedatives, regarding TIVA. And if you think that hypotensive anesthesia is of benefit, definitely we will go for that. And when we have our backing up with this randomized control trials, then it takes precedence.
Dr. Banerjee, also I have some experience that someone is used. I have also used sometimes injection tranexamic acids during the operation and pre-operatively to reduce the bleedings during the operations.
Yes.
So, is there any other experience you can discuss it?
Preoperative Trenexa is good idea. When it starts bleeding, then Trenexa has no role.
No, you have do you are using preoperative Trenexa routinely?
I am using, sir, preoperative.
So in EPOS 2020 guidelines also, they have suggested that perioperative use of tranexamic acid has been shown in some papers to be effective, though they do not have any randomized control trials report. So I think we have considered all the suggestions and questions. Oh, another one is there. Dr. Soumitra Kumar asked, does mitomycin C help in preventing scarring? And Dr. Bikram Khanna replied that it has no role.
That is true.
So what about our panelists?
Mitomycin C was tried earlier, but then it fell out of DCR also and endoscopic sinus surgery also. They were using it in
Yes.
So Dr. Khanna suggested that meticulous surgery giving full priority to healthy mucosa preservation as the surgical key, and daily nasal irrigation and regular debridement is the norm. So I think if our panelists permit, we can end our discussion here.
Yes, sir. We have done a long discussion.
Yes.
A very long discussion, very fruitful discussion.
Yes, yes.
So I hand over the microphone again to Dr. Sinusitis Burman.
Thank you, Dr. Somendranath Bandyopadhyay, for wonderful moderation of the whole session. It was an excellent academic discussion. I thank Dr. Gautam Khan, Dr. Sanjeev Kumar, Dr. Samit Lal, and Dr. Utpal Jana for sparing your valuable time with us and sharing your knowledge with us. I also thank Dr. Doipan Mukherjee for his excellent speech. I hope all the audiences have enjoyed the evening. I thank all the audiences for joining the meeting and also sharing your comments and questions and making the academic discussion more interesting. All the academic programs of AOI West Bengal are available on our YouTube channel. I request you all to subscribe to our channel and give a like and view all our events. Lastly, I thank Sanofi for continuously supporting all our academic events. Now I request Dr. Doipan Mukherjee, mentor of today's event, to say a few words.
No, actually, Dr. Somendranath Bandyopadhyay, Dr. Sinusitis Burman, Dr. Utpal Jana, they told everything. Right now, I will request Dr. Gautam Khan to say a few words for his upcoming conference.
Thank you, Doipan. Thank you very much. We were planning to hold the Indian Academy annual meeting in Guwahati in 2020 November. So because of COVID, it got postponed. But in 2021, it was ultimately decided to be virtual. So we are having the virtual meeting on 26th, 27th, and 28th of November. There are a lot of good speakers from national and international. And some of the speakers are also in the panel on the screen. So please do register. I think you'll be benefited. We are trying for the CME credits, but till now there's some controversy regarding giving CME credits in virtual meetings. So let's see if it works out. I welcome you all to kindly join and.
Surely, surely. Congratulations, sir. We'll be
So,
there.
And Dr. Samit Lal,
conferences.
Yeah,
Each zone is having two big conferences. One virtual, one physical.
Yeah.
But everybody is more interested.
Dr. Samit Lal already told regarding AOICon. Dr. Sanjeev, do you want to add something regarding AOICon, Rachi?
Actually, I always request all of you, the East, the Northeast and the West Bengal, the Bihar and the UP, you should come forward in big way for these conferences. And because of the COVID post-pandemic, the travel is restricted. So the nearby states should support strongly. And then we will have a great grand conferences.
We all will be there.
Yeah.
Thank you.
Yes.
Thank you.
Okay. Now I like to request Mr. Manoj Joshi to say a few words on behalf of Sanofi.
Yeah, thank you, Dr. Sab. I will just take a couple of minutes. Sir, respected doctors, on behalf of Sanofi, I wish to extend my sincere thanks along with my all colleagues to all the paneling eminent clinicians and the participant as well. Despite personal commitments on Sunday evening, you have taken out your valuable time, allocated almost an hour or more than that to this scientific debate. We are really grateful to you. Sir, in fact, we are thankful to AOI West Bengal for making it in true sense East Zone Conference. We have a representation from Jharkhand, Bihar, West Bengal, and nicely moderated and very well executed session. I would
From Assam also, Assam.
Yeah. And sir, great representation, sir. And I would like to thank all the doctors who have joined out of Eastern Zone as well. I think we have a few doctors, Dr. Khanna was mentioning, sharing the expertise and experience as well. So thank you so much, sir, to all of you. Before I close, I would just request you, whenever there is an opportunity, kindly give us opportunity to connect through digital mode till the time the situation is completely normalized. I would also request you to pass on the benefit of our brands to your patients. We have strengthened a respiratory portfolio with Allegra 1, Allegra 180, Allegra Suspension, Allegra Nasal Spray was launched a couple of years back. Now we also have a new baby in a product kitty, that is Allegra Nasal Duo, which is a combination of Azelastine plus Furet, and which really is a different brand, adding a lot of value to the whole therapy area and treatment with the addition of Neotin, which is a new test masking agent, which is approved by US FDA. So earlier patient compliance challenge with Azelastine combination is being taken care completely with Allegra Nasal Duo. So we look forward for the brand's patient benefit, and the brands are available. Thank you once again, Dr. Saab, for giving us this opportunity. We also extend our sincere best wishes for 2 mega conferences, as sir has rightly mentioned, at Ranchi as well as Guwahati. So thank you. Stay safe. Happy festivities ahead.
Thank you. Thank you so much.
Okay. Thank you.
So Snehashish, I think we can go offline now, and please stay for 5 minutes.
Yeah.
Zoom.
Aparupa, please make it offline.
Aparupa,